Welcome back to the deep dive. Today, we're doing something a little different, and frankly, the stakes feel a little higher than usual.
They certainly do.
Usually, we're just satisfying our curiosity, but today we are simulating a high-pressure scenario.
Exactly. This isn't just about general knowledge. We're stepping right into the shoes of a resident, preparing for their final MD anesthesiology exams.
And we're being specific about it, too. We're looking at this through the lens of a candidate at, say, Gujarat University, or really any major board exam where the examiners are just waiting for precision.
They are. They're looking for that deep physiological understanding.
Right. So I'm playing the role of the resident, and I'm sweating bullets because I've just pulled a card from the bowl that says anesthesia for fetal surgery. And you...
Well, I suppose that makes me the senior faculty. Or maybe that intimidating external examiner sitting across the table.
Definitely intimidating.
I'm waiting to see if you really understand the physiology or if you've just memorized a list of drugs and procedures.
Terrifying, but I suppose necessary. We've got a stack of heavy hitters here to guide us. Miller's Anesthesia, the new 10th edition, of course.
The Bible.
Morgan and Mikhail, and those really specific Indian exam guides like Kaushik Jothanath, which are, indispensable for these topics.
So our mission really is to turn this huge amount of reading into a structured, high-yield audio revision guide that you can actually use.
Exactly. And you mentioned fetal surgery as a favorite for examiners. Why is that? It seems so niche, so specialized.
Because it tests everything. It's the perfect topic. To answer it well, you have to master maternal physiology, fetal physiology, complex pharmacology, and crisis management, all at the same time.
So it's a synthesis question.
It's the ultimate test of an anesthesiologist's ability to manage two patients at once. And these two patients, remember, often have completely opposing physiological needs.
That's a great way to put it.
Honestly, if you can demonstrate you can handle a fetal surgery case, you're showing the examiner you can handle almost anything in obstetric anesthesia.
Okay, that makes sense. So let's start Part A, Introduction and Concept. If this is my 20-mark long answer, how do I frame that introduction? Where do I begin?
You start with a clear definition and then immediately state the rationale. So fetal surgery is a therapeutic intervention performed on the fetus.
In utero.
In utero, exactly. But the why is the most crucial part. We don't just operate for the sake of it. We operate to prevent irreversible organ damage, or in some cases, fetal death.
Irreversible is the key word there, isn't it?
It is the key word. You have to use it. If we can wait until the baby is born and fix it, then we do. We only intervene when waiting would be a catastrophe.
So, for example, the lungs might be too underdeveloped to ventilate.
Precisely. Too hypoplastic.
Yeah.
Or kidneys might be too damaged from an obstruction. We intervene when the fetus would either die before term or suffer permanent harm that neonatal surgery just can't fix.
So we're changing the physiological trajectory of the fetus.
That's a very elegant way to put it, yes. And in your introduction, you must state the role of the anesthesiologist.
The guardian of two lives.
The two-patient challenge, yes.
Yeah.
You have to write that phrase. Well, maternal safety is always, always primary. You can never forget that.
Underline it in my head.
But you are also responsible for the fetus. The fetus is the patient undergoing the surgery. It needs immobility, it needs analgesia, and it needs a stable placental environment to survive.
And that's the balancing act, balancing maternal hemodynamics with fetal perfusion.
That's the entire game.
Okay, let's move on to the indications. This feels like a very high-yield section for a short note, or maybe the opening volley of Aviva. What are the big ones I absolutely need to list?
You should stick to the big five that examiners always look for. First, congenital diaphragmatic hernia, CDH.
Right, where the abdominal contents, the gut herniate into the chest through a hole in the diaphragm.
Correct, and in doing so, they compress the developing lungs. So the goal here is to prevent severe pulmonary hypoplasia.
And the procedure for that is Feto.
Yes, fetoscopic tracheal occlusion.
Can we just pause on Feto for a second? Why on earth does plugging the trachea help the lungs grow? That sounds completely counterintuitive.
It does, doesn't it? But it's based on a fascinating piece of physiology. Fetal lungs aren't for breathing. They are secretory organs. They're constantly producing fluid.
Okay.
Normally, this lung fluid flows out of the trachea and into the amniotic fluid. With Feto, we go in with the scope and place a small balloon to block the trachea.
So you're damming the river, so to speak.
Exactly. The fluid backs up and builds up inside the lungs. It's like inflating a water balloon.
And that pressure, it stretches the lung tissue.
That mechanical stretch is a powerful signal for cellular growth. It stimulates lung hyperplasia. It essentially forces the lungs to expand against the herniated bowel and grow bigger than they otherwise would.
That is brilliant. Okay, so CDH is number 1. What's number 2?
Neural tube defects, and specifically myelomeningocele. This is the spina bifida repair.
And for this, I have to mention the Maumles trial.
You absolutely must mention the Maumles trial. It's the landmark study, the management of myelomeningocele study.
And what did it prove?
It proved quite definitively that closing that spinal defect in utero significantly reduces the need for ventriculoperitoneal shunts for hydrocephalus later on.
And better motor outcomes too, right?
And much better motor outcomes at 30 months compared to fixing it after birth.
Why, though? Why is it so much better to do it inside?
Because of something called the two-hit hypothesis, a great phrase for the exam.
Okay.
Hit 1 is the genetic or developmental failure of the neural tube to close. That's the initial problem. But hit 2 is the ongoing chemical and mechanical damage.
From what?
From the amniotic fluid. The spinal cord is just floating, exposed. And as gestation progresses, the amniotic fluid becomes increasingly toxic to neural tissue.
So by covering it up, we're protecting it.
You stop that continuous damage, but there's more. You also stop the leak of cerebrospinal fluid, the CSF leak, from the spine.
And that's what causes the hydrocephalus.
It's what causes the hindbrain to be pulled down into the spinal canal, the Arnold-Chiari II malformation. When you plug the leak in utero, that herniation can actually reverse. It's remarkable.
Reverses hindbrain herniation. That's a fantastic point for an exam answer. Okay, so we have CDH, neural tube defects. What's third?
Twin transfusion syndrome, TTTS. This only happens in monochorionic diamniotic twins, identical twins that share a single placenta.
And one twin basically becomes a donor and the other a recipient.
Yes, through abnormal blood vessel connections, or anastomosis, on the placental surface. One twin, the donor, gets anemic and small, while the recipient gets overloaded with blood, becoming polycythemic and developing heart failure.
And the treatment is laser ablation.
Correct. We go in with a fetoscope and use a laser to find and burn those connecting vessels, effectively separating the two circulations.
Okay, fourth indication.
Obstructive uropathy. The acronym is LUTO for lower urinary tract obstruction.
Usually posterior urethral valves in a male fetus.
That's the classic example. The bladder can't empty, so it balloons up, causing back pressure that destroys the developing kidneys.
And it has another effect too, right? With the amniotic fluid.
A critical one.
Mm.
The fetus produces amniotic fluid primarily by urinating. If there's no urine output, the amniotic fluid level drops catastrophically. That's called oligohydramnios.
And the lungs need that fluid to develop properly.
Exactly. No fluid, no lung development. So we intervene by placing a vesicoamniotic shunt, a little tube that drains urine from the bladder directly out into the amniotic space.
Saving both the kidneys and the lungs. Makes sense. And the last one on our list of 5.
Sacrococcygeal teratoma, SCT.
This is a massive tumor at the base of the tailbone.
It can be, and they are incredibly vascular. If it gets too big, it acts like a giant arteriovenous fistula, stealing a huge amount of blood flow from the fetus.
Leading to high-output cardiac failure.
Yes, and a condition called hydrops fetalis, which is massive fluid overload and is usually fatal. So for very large vascular SCTs, we may need to go in and resect the tumor to save the fetus. Got it. CDH, MMC, TTTS, LU2O, SCT. That's a solid list. Now, moving to Part B classification. I feel like this is where students can get tripped up, thinking all fetal surgery is basically the same.
And that would be a major mistake in an exam. It is absolutely vital to distinguish them because your anesthetic plan is completely different for each type.
So how should I structure it?
You must classify them into 3 distinct buckets. Bucket 1, minimally invasive, which includes fetoscopic or percutaneous procedures.
So like the laser for TTTS, or the balloon for CDH, or the shunt for LUT?
Correct. Bucket 2, open fetal surgery.
This is the heavy lifting.
This is the heavy lifting. This involves a maternal laparotomy, just like a C-section, followed by a hysterotomy, an incision into the uterus itself to expose the fetus for the repair.
The myelomeningocele repair would be an open procedure.
Classically, yes. And bucket 3.
The Oxide procedure.
Exactly. Ex utero interpartum treatment. And we have to discuss that separately because, as you said earlier, it's a beast of its own. So, anesthetically speaking, what is the single biggest difference between a fetoscopic case and an open case?
One phrase. Uterine relaxation.
Okay, explain that.
In fetoscopic surgery, we're just poking 1 or 2 small trocars through the uterine wall. We don't necessarily need the uterus to be completely flaccid. In fact, some tone is helpful.
But in open surgery?
In open surgery, you are making a large incision into that big irritable muscle. If the uterus contracts even slightly,
It could push the fetus out, or worse, shear the placenta right off the wall.
a placental abruption, a catastrophe. So for open surgery, you need profound, absolute uterine relaxation, total flaccidity.
And that one requirement, profound relaxation, is what's going to dictate my entire choice of anesthetic.
Completely. It's the central pillar of your management plan.
Okay, that's a perfect transition. But before we get to the drugs and techniques, we have to handle the physiology. Part C, maternal fetal physiology. This is pure Viva table territory. Let's start with the mother.
The cardiovascular changes of pregnancy are dramatic, and you need to know them cold. By the second trimester, cardiac output is up by 40 to 50%.
A huge increase.
Huge. But at the same time, systemic vascular resistance, SVR, is down, thanks to progesterone. The circulation is in a high-flow, low-resistance state.
And now for the big exam trap.
Aortocaval compression.
Yeah.
When a pregnant patient lies flat on her back, the gravid uterus acts like a paperweight,
And it sits right on top of the inferior vena cava.
crushing it.
Uh,
This drastically reduces venous return to the heart,
Yeah.
reduces preload.
And also compresses the aorta.
To a lesser extent, but yes.
Yeah.
It reduces blood flow to the uterus and the lower extremities. In the exam, if you do not mention left lateral tilt, you fail that station. It's that important.
It's non-negotiable.
It's absolutely non-negotiable. You can use a wedge under the right hip, but that tilt, even just 15 degrees, makes a massive difference in cardiac output.
Got it. What about the respiratory changes? They're just as important for us.
They are. The diaphragm gets pushed up by the uterus, so the FRC, the functional residual capacity, drops by about 20%.
So she has less oxygen reserve to begin with.
Exactly. And at the same time, her oxygen consumption is up by 20 to 40% to support the fetus and placenta.
Less reserve, more demand. That sounds like a recipe for disaster during induction of anesthesia.
It is. A pregnant patient desaturates incredibly fast during apnea. You have a very, very short window to secure the airway. This is why every pregnant patient is considered a potential difficult airway with a high risk of rapid desaturation.
And there's a nuance about CO2, isn't there? I see this question come up a lot.
This is a classic Viva question. Progesterone is a respiratory stimulant, so pregnant women naturally hyperventilate. Their normal PaCO2 is not 40, it's around 30 to 32 millimeters of mercury.
So they live in a state of compensated respiratory alkalosis.
Precisely. Now here's the trap. You're ventilating her during surgery.
Huh.
What do you set your end-tidal CO2 target to?
I'm tempted to say 40 because that's normal.
And that would be the wrong answer. You do not normalize her to 40. If you let her CO2 rise to an adult normal, she is actually respiratory acidotic relative to her baseline.
Ah, I see.
And even more importantly, the fetus relies on that CO2 gradient between its blood and the mother's blood to offload its own CO2 waste. If you raise the mother's CO2, you reduce that gradient, and the fetus can become acidotic.
So maintain the pregnant normal. Aim for a PaCO2 of around 30.
Yes. Keep her at her baseline.
Okay, let's flip the coin now and talk about the other patient, the fetus.
For the fetus, you have to remember one thing above all else. It has no functional lungs. Oxygenation is 100% dependent on the placenta.
And fetal hemoglobin is different. It's adapted for that environment.
It is. HbF has what we call a left shift on the oxygen-hemoglobin dissociation curve. Its P50 is about 18 millimeters of mercury compared to the adult P50 of 27.
What does that mean in practical terms?
It means fetal hemoglobin has a much higher affinity for oxygen. It grabs oxygen greedily from the maternal blood in the placental intervillous space. It's very efficient at uptake.
But the trade-off is that it doesn't release it to the tissues as easily.
Correct. The fetus lives on the brink of what an adult would consider profound hypoxia. Its environment is optimized for growth, not for high-energy activity.
Let's talk about uterine blood flow, or UBF. I've seen the formula in Miller, and it seems critical.
You must memorize this formula. UBF equals uterine artery pressure minus uterine venous pressure, all divided by uterine vascular resistance.
So what's the clinical takeaway from that equation? What does it really mean for me?
It means that uterine blood flow is not autoregulated. The vessels are already maximally dilated. They're just passive conduits. Flow is entirely pressure dependent.
So if mom's blood pressure drops,
Uterine flow drops linearly with it. There's no protective mechanism. And if the uterus contracts, the venous pressure and vascular resistance go way up.
and flow plummets.
Exactly. So your job as the anesthesiologist is to maintain maternal mean arterial pressure and prevent uterine contractions during surgery.
That's crystal clear. Last bit of physiology, placental drug transfer.
The placenta is not a barrier. It's more of a sieve. Simple diffusion is the main mechanism.
And the rule of thumb is that lipid-soluble, small molecules cross easily.
Yes, low molecular weight, high lipid solubility, and non-ionized drugs will all cross the placenta very readily. This is why our volatile agents and opioids get to the fetus.
What about this concept of ion trapping? It sounds like a great thing to drop in Aviva.
It's a fantastic concept to mention. The key fact is that fetal pH is normally slightly lower, more acidic than maternal pH.
Okay.
So when a weak base, like a local anesthetic or an opioid, crosses the placenta from the mother's more alkaline blood into the fetus's more acidic blood, it picks up a hydrogen ion. It becomes ionized.
And ionized drugs are charged so they can't cross back over the lipid membrane of the placenta.
Exactly. They get trapped in the fetus. This can lead to a dangerous accumulation of the drug in the fetus, especially if the fetus is already acidotic from stress.
Wow, that's a subtle but really important point. Okay, we've set the physiological stage. Now for the main event. Part D, anesthetic management. The examiner leans forward and asks, what are your goals?
You should be able to list 5 main goals clearly and concisely.
Let's hear them.
1, maternal safety, airway management, aspiration prophylaxis, and hemodynamic stability. This is number 1, always.
Go ahead.
2, fetal immobility. The surgeon is doing microsurgery. The fetus cannot move.
3.
3, fetal analgesia and blunting of the stress response.
4 has to be uterine relaxation.
4 is uterine relaxation, absolutely critical for open cases to prevent placental abruption and allow surgical access. And finally, 5, postoperative tocolysis, preventing preterm labor after you're all done.
That's a great framework. Now let's talk about the techniques to achieve those goals, general versus regional.
For those minimally invasive or fetoscopic surgeries, regional anesthesia, so a spinal or an epidural, is often the preferred technique.
And the advantages there are pretty clear.
Very. The mother is awake, so she can protect her own airway. There's much less drug transfer to the fetus, and you get excellent postoperative pain relief.
But for open fetal surgery,
It has to be general anesthesia. There's no other option.
and the reason is what we talked about before.
It's that one single reason.
Oh.
You need that profound uterine relaxation, and you simply cannot achieve a truly floppy uterus with a spinal or epidural. You need the direct effect of volatile anesthetics on the myometrium.
Okay, this brings us squarely to the uterine relaxation and tocolysis section. This seems to be the absolute crux of the management.
It is. For open fetal surgery, our primary tool for uterine relaxation is running high concentrations of volatile agents.
Like desflurane or sevoflurane?
Yes, and we're talking about concentrations of 2.0 FA, or sometimes even higher.
2 MEC.
Uh-huh.
That's enough to drop a horse. That's going to cause profound maternal hypotension.
Of course. That's the trade-off. It's a controlled hypotension. You use the volatile to get the massive uterine relaxation you need to keep the placenta attached.
But you have to aggressively support the maternal blood pressure.
Aggressively. A phenylephrine infusion is standard practice. You are essentially balancing the vasodilatory effects of the gas with the vasoconstrictive effects of the pressor to maintain a stable MAP and therefore a stable uterine blood flow.
What if the gas isn't enough? Or let's say, hypothetically, you were doing a TIVA technique.
Good question. If you were doing TIVA total intravenous anesthesia with propofol and remifentanil, you must remember that propofol does not relax the uterus. It provides no tocolysis.
So you'd have to add something else specifically for that.
You must add a dedicated tivaglytic. The most common intraoperative choice would be a bolus of nitroglycerin or NTG.
How much?
You can give small boluses of 50 to 100 micrograms. It's incredibly potent.
And it works fast.
It works in seconds. It's often used as a rescue tocolytic if the uterus starts to firm up, even with high gas concentrations. But, again, like the volatiles, it's a potent vasodilator, so it will also drop the blood pressure.
Okay, speaking of tocolysis, how do we manage it after the surgery is over? We can't keep her on 2 MAC of SIVO in the recovery room.
No, you can't. The moment you wake her up, the volatiles wash out and their tocolytic effect is gone. The uterus might start to cramp and contract.
Which could trigger preterm labor.
The biggest risk. So we immediately start them on other tocolytics. The first-line agent is often a magnesium sulfate infusion. We give a loading dose followed by a maintenance infusion.
And I've seen indomethacin used as well.
Yes, very commonly, usually as a rectal suppository right at the end of the case. Nifedipine, a calcium channel blocker, is another option.
Is there a risk with indomethacin? I remember reading something about the ductus arteriosus.
There is. Indomethacin is a prostaglandin inhibitor, and prostaglandins are what keep the fetal ductus arteriosus open. So if used for too long, it can cause premature closure of the ductus.
So it's a short-term solution.
Exactly. We typically limit its use to 48 hours post-op, but for that immediate high-risk period, it's a standard and effective part of the regimen.
Now, here's something I found absolutely fascinating in the sources. We don't just anesthetize the mother, we have to anesthetize the fetus specifically.
Yes, and this is a critical point. The old dogma that babies don't feel pain is dead and buried.
When can they feel it?
The fetus can definitely perceive pain and mounts a massive stress response, a surge of catecholamines, cortisol, from about 18 to 24 weeks of gestation onwards. If the surgeon makes an incision on the fetus, it will react, it will move.
And movement is bad for microsurgery.
Disastrous. You can't repair a tiny spinal defect on the moving target. So we absolutely need fetal anesthesia and, crucially, fetal immobilization.
So how do we actually give it?
There are two main routes. The first is transplacental.
So the drugs we give the mom cross over.
Correct. The mother's volatile agents and any opioids, like remifentanil, cross the placenta and will provide a baseline level of sedation and analgesia to the fetus. But often, that's not enough to guarantee total immobility.
So we have to go direct?
We have to go direct. This is where we use the fetal cocktail. This is an absolute exam favorite question. The surgeon uses ultrasound to guide a long, fine needle through the maternal abdomen, through the uterine wall, and into the fetus.
Into the muscle.
Usually into the fetal gluteal muscle or the deltoid, an intramuscular injection.
And what's in this cocktail? Can you give me the specific drugs and maybe even the dosages for my exam answer?
Of course. Write this down. The cocktail typically contains 3 components. First, an opioid for analgesia, usually fentanyl at a dose of 10 to 20 micrograms per kilogram of estimated fetal weight.
Okay, fentanyl for pain.
Second, a muscle relaxant for paralysis, usually vecuronium at a dose of 0.2 milligrams per kilogram. Vecuronium is also used. This ensures complete immobility.
And the third drug?
Atropine at 20 micrograms per kilogram.
Why atropine?
Because the fetus has a very strong, very reactive vagal response to surgical manipulation. The heart rate can plummet dangerously.
So it's to prevent bradycardia.
Yes, and you must remember, fetal cardiac output is almost entirely rate dependent. They can't increase their stroke volume like an adult can. So if the heart rate drops, cardiac output and perfusion drop with it. Atropine keeps the rate stable.
That's a fantastic practical explanation. Okay, let's move on to Part E monitoring and intraoperative care.
For the mother, it's all the standard ASA monitors, plus, almost always, an invasive arterial line.
Because of the high volatiles and the need for beat-to-beat blood pressure monitoring?
Precisely. For the fetus, intraoperatively, ultrasound is the gold standard. A pediatric cardiologist is often in the room, performing a continuous fetal echocardiogram. We're watching the heart rate, the contractility, signs of fluid overload.
Can we actually use pulse oximetry on a fetus?
We can. During an open surgery or an XT procedure, the surgeon can place a small, sterile pulse oximeter probe on the fetal hand or foot.
What's a normal saturation for a fetus? I imagine it's not 98%.
Not even close. And this is the key point. You can't panic when you see the number. A normal fetal saturation is around 60%.
60. Wow.
Remember, they live in a state of relative hypoxia. Their blood is what we'd consider venous or mixed venous. So anything above 50 to 60% is usually considered acceptable and reassuring.
That's a great clinical pearl. What are the big intraoperative complications we need to be ready to manage?
Number 1 is maternal hypotension. We've discussed it, but it bears repeating. You have to treat it aggressively with your pressor of choice.
And that choice is phenylephrine. But I know that old textbooks, even some I read in residency, used to say ephedrine was better because phenylephrine, being a pure alpha agonist, might constrict the uterine arteries.
That is the old dogma. And you should say that in your Viva. The old dogma favored ephedrine.
But current evidence suggests phenylephrine is preferred.
Exactly. Current evidence, and Miller's very clear on this, shows that phenylephrine is safe and effective. It maintains maternal pressure without causing fetal acidosis. Ephedrine, on the other hand, crosses the placenta, can increase fetal metabolism and oxygen demand, and has been associated with a lower fetal pH.
So phenylephrine is the go-to now.
It is the modern standard of care in this setting.
What's another major complication?
Maternal pulmonary edema. The risk is huge. We sometimes call it the triple whammy.
Okay, what are the 3 parts?
1. Tocolytics. Magnesium sulfate is notorious for causing fluid retention and vasodilation. 2. Steroids, We often give the mother betamethasone before surgery to help mature the fetal lungs, and steroids cause fluid retention.
And 3.
3 is just iatrogenic fluid administration. And on top of that, especially in endoscopy, the irrigation fluid used by the surgeon can be absorbed systemically by the mother.
So the take-home message for the anesthesiologist is to be incredibly stingy with intravenous fluids.
A very restrictive fluid strategy is essential. You do not want to drown the patient in the post-op period.
Now, let's tackle the beast. Part F, the exit C procedure. This is an absolute exam favorite.
It is. The exit procedure ex utero intrapartum treatment. You must start by defining it very carefully. It is not just a C-section.
What's the fundamental difference?
In a C-section, the goal is to get the baby out and clamp the cord as quickly as possible. In an exit, we are deliberately doing a partial delivery while maintaining placental circulation.
We deliver just the head and shoulders, but keep the rest of the body inside the warm uterus.
Exactly. Why do we do that?
To keep the uterine volume high, which prevents the myometrium from contracting down and causing the placenta to separate.
You're using the placenta as a heart-lung bypass machine for the baby. It's placental support.
And the main indication is a fetus with a predicted airway obstruction, like a giant neck mass or a congenital high airway obstruction.
Precisely. Or for a planned removal of a tracheal balloon that we put in for CDH, you need time to secure a definitive airway on the baby before it has to breathe on its own.
Okay, walk me through the anesthetic dance of the exit procedure. It sounds incredibly complex.
It's a game of two halves. Phase 1 is what I call controlled hypotonia. Your single most important goal is profound uterine relaxation.
So deep GA.
Deep GA, 2 to 3 MA of volatile agent. You want that uterus to be completely boggy and relaxed so it doesn't contract and shear off the placenta while the baby is halfway out, all while maintaining maternal MAP with pressors.
The surgeon then does the hysterotomy, maybe using a special stapling device to control bleeding.
Yes, and they deliver just the head and chest of the baby. They do not clamp the umbilical cord.
My clock is ticking.
The clock is ticking. The pediatric surgeons then get to work. They might perform a laryngoscopy, a bronchoscopy, secure an endotracheal tube, or even perform a full tracheostomy on the neonatal neck. This can take 30, 60, even 90 minutes.
And all that time, the anesthesiologist is just staring at the uterine tone and the maternal blood pressure.
Constantly. And then comes the pivot. The moment the airway is secured and the surgeons say, "We are ready."
Phase 2 begins. The reversal.
The reversal. The instant they clamp the umbilical cord, your goals flip 180 degrees. You no longer want relaxation. You now have a floppy, atonic uterus that is about to bleed to death.
So you have to wake the uterus up. Fast.
Instantly. You slam the volatile agent to 0. You turn on the high-dose oxytocin infusion that you had ready. You tell the nurse to give methylorgometrin or carboprost. You need that uterus to clamp down into a hard rock instantly to prevent a massive postpartum hemorrhage.
That sounds like one of the most high adrenaline moments in all of anesthesia.
It is. The anesthesiologist is the one who orchestrates that entire critical transition from placental bypass to neonatal life and then to maternal safety.
Let's move to Part G, postoperative care. It's not over when the surgery ends.
Not at all. Maternal pain control is vital. Pain causes a catecholamine release, and catecholamines constrict uterine vessels and can provoke contractions.
An epidural placed before you start is an excellent option for post-op pain.
The gold standard if possible. Anticolysis continues, of course.
Usually the magnesium infusion or maybe oral nifedipine to prevent preterm labor in the days following.
Correct. And you must monitor her closely in a high-dependency unit or ICU, especially for any signs of that delayed pulmonary edema we talked about.
There's one other long-term implication for the mother that feels important for a full answer.
A very important point, especially for the counseling aspect of a VIVA question. If a mother undergoes an open fetal surgery, the hysterotomy incision is not in the lower segment like a normal C-section. It's in the upper muscular part of the uterus, the corpus.
The part that does all the contracting during labor.
Right, and that scar is inherently weak. This means for all future pregnancies, she must have a planned cesarean section, likely before labor even starts. She can never be allowed to labor again.
Because the uterus might rupture.
A catastrophic risk.
Okay, this is all coming together. Part H, exam integration. Let's try to create a mental model, a comparison table for the 3 types of surgery.
Okay, perfect. Let's do it as a quiz. Imagine 3 columns. First column, minimally invasive or fetoscopic surgery. What's the typical anesthetic?
Usually regional, like a spinal or epidural, sometimes sedation.
Good. Is uterine relaxation critical?
No, not as critical as in open surgery.
And what's a major risk specific to that procedure?
Preterm, premature rupture of membranes, PPROM, from the trocar sites.
Excellent. Now, column 2, open fetal surgery. Anesthesia.
Has to be general anesthesia.
Uterine relaxation.
Essential, absolutely critical, achieved with high-dose volatiles or NTG.
And the main risks.
Preterm labor post-op, and the risk of uterine dehiscence or rupture in a future pregnancy.
Perfect. Finally, column 3, the Oxide procedure. Anesthesia.
Deep general anesthesia.
Uterine relaxation.
It's a tale of two halves, essential until the cord is clamped, then it's immediately contraindicated.
And the biggest, most immediate risk to the mother.
Massive postpartum hemorrhage from uterine atony. That's brilliant. Having that table in my head makes it so much clearer. Let's hit some common Viva traps, the things an examiner might ask to try and trip me up.
All right, trap number 1. The examiner says, can you use nitrous oxide as part of your anesthetic?
My gut says no.
And your gut is right. Why?
Because it expands gas-filled spaces. So if the fetus has a CDH or any kind of bowel issue, you're going to distend the bowel loops, making it impossible for the surgeon to close the defect.
Correct. And a secondary reason.
It significantly increases the risk of postoperative nausea and vomiting for the mother. Best to avoid it.
Good. Trap number 2. The fetus is moving during the surgery. Do you deepen the mother's anesthetic?
You have to be careful here. Deepening the mother further with more volatile could cause dangerous hypotension and compromise uterine blood flow. The better answer is to ask the surgeon to administer a direct fetal IM muscle relaxant from the fetal cocktail.
That is the perfect safe answer.
Track number 3. What is your primary tocolytic during an open fetal surgery?
This one feels too easy. It's not the magnesium you'll use later.
No, don't forget the obvious one, the volatile anesthetic itself. The 2-MSC of sevoflurane is your primary moment-to-moment tocolytic agent during the case.
Exactly. Don't overthink it. And finally, let's talk diagrams. If I'm writing the long answer, what should I draw to impress the examiner?
Examiners love simple, clear diagrams. First, draw a simplified fetal circulation. Show the 3 shunts, the ductus venosus, the foramen ovale, and the ductus arteriosus. Show how the oxygenated blood from the placenta bypasses the liver and lungs.
Okay, that's doable.
Second, draw a flowchart for the EGOX-IT procedure. Just simple boxes and arrows. Induction, deep GA for relaxation, hysterotomy, airway secure, cord cramp, oxytocin, volatiles off the way up. It shows you understand the critical sequence.
That's very helpful. So to summarize this entire deep dive, what's the one-sentence takeaway?
You are managing 2 physiologically distinct patients with often competing needs.
Yes. For the mother, you prevent aspiration, you maintain her blood pressure at all costs, and you manage the profound effects of the drugs needed for the surgery. For the fetus, you provide oxygen by maintaining maternal perfusion, and you provide direct anesthesia and paralysis to make the surgery possible.
And the ultimate goal is not just to survive the surgery,
but to correct the defect and keep the pregnancy going for as long as possible. It's fetal therapy, not just a technical operation.
This has been an incredible run-through. I honestly feel so much more ready for that 20-mark question now.
Good. Just remember the core principles. Think like a physiologist, but act like a clinician. Safety first for both of your patients.
And for all of you listening, whether you're prepping for your MD exams at Gujarat University or anywhere else in the world, or maybe you're just fascinated by the absolute extremes of medicine, we hope this deep dive has given you a really solid framework.
Good luck with the preparation.
That's it for this episode of The Deep Dive. We'll catch you next time.